Good afternoon, everyone. Thank you for your time and attention on what I'm hoping is a beautiful afternoon in May. My name is Dan Rundy. I am a clinical associate professor of emergency medicine at the University of Iowa, and I'm here to talk to you about the double 8 mask brace and the way that it improves fit and protection of a basic surgical mask. So I have no relevant disclosures, although I would like to thank colleagues at a website called fixthemask.com who had approached me about a year ago with the idea of testing this rubber band mask brace concept, and they didn't have the resources to do that, and so reached out to see if somebody at an academic center might be willing to take a look in this, and very happy that they put the idea across our plate, as you'll see in future discussion. So I know that it's been talked about ad nauseum at this conference and just in the world in general, but our lives, both personal and professional, in the last year have been subsumed by the SARS-CoV-2 pandemic and the first, second, and third waves. And that impact and that tension was probably never more acute than at the beginning when we were dealing with something of an unknown commodity and also having to face it in the setting of lack of adequate personal protective gear. And we all remember the stories about the lack of PPE, and most specifically, most acutely for what we do in the emergency department was probably the lack of available N95 respirators. And that was a problem both abroad and here in the United States. We saw that, and we certainly felt that. I don't think that very many of us who have been practicing ever thought we were going to see the day where we were holding on to an N95 mask and reusing it time and time again. Not because we felt like that was the best thing to do, but because what we had to do. So realizing that N95s weren't available, and also at the same time that going backwards and adopting something like the plague mask, while intimidating and potentially fashionable, was probably going to impact negatively our Press Ganey scores, I had the thought of having to do what we do in the emergency department all the time, which is innovate and find a solution in a resource and time-limited environment. And so this is that solution, or at least partial solution. So as you can see, this double 8 mask brace, as we've decided to call it, is really nothing more than 3 rubber bands looped together to form sort of a central loop and then 2 outer loops, or as we call it, the double 8 figure. And the idea was that with a brace like this, you might be able to improve the fit of a basic surgical face mask and thereby increase the margin of safety for people that were wearing these masks in potentially COVID-exposed environments. So there were a number of ways that you could apply this mask. The ones that we found, this mask brace, the ones that we found most effective were applying this mask brace using a paper clip to anchor the rubber bands behind the head. It was both more comfortable and provided a better degree of fit and face seal. So this figure there just demonstrates the way that you might apply this and then have it fit on your face. The subsequent figures demonstrate proper positioning for the rubber band brace. So there's sort of 2 central knots, and they provide the lateral margins. So you want those centered still within the bounds of the face mask, and then superiorly over the bridge of the nose and under the chin, as you can see in figure G. And then as face shields became more commonly adapted, it provided an ideal anchor point for this mask. So this was both the most comfortable, just per feedback from the people who had to wear it, and also, as you'll see later, provided the best fit. So what did we do then? We decided to formally test this, and we basically subjected it to any of you who have sat down for an N95 fit test. That's what we did with this mask. So we got a Port Account Pro and took a regular basic ASTM level 1 face mask, these yellow masks that you might be familiar with, applied the mask brace across a range of volunteers, and then tested them in 3 scenarios: anchored behind the ears, anchored with a paper clip, and anchored on a face shield, and subjected them to the fit testing, the quantitative fit testing that you would undergo when you're getting fitted for an N95. And so we had 11 subjects, a good mix of male and female candidates, a good range of body habituses, and a good range of, we didn't have a surrogate for facial morphology. We used the different N95s that people were fitted for, and there were 5 different types of N95s that the subjects in the study had been formally approved for within the last year within our hospital system. So as you can see from this figure, when this very simple brace was anchored either with a paperclip behind the head or with a face shield, all the subjects passed the certification level required for N95 level face seal. So again, that's not an N95 level mask all around, but in terms of the seal that this brace creates, you were getting that same level of protection. We also had one of our collaborators is a professor of occupational and environmental health and actually runs a NIOSH certified lab and was able to do tests on the breathability, so basically at resting and at exertional levels of this mask and how do you get the air in and out, and found that it more than met the breathability requirements laid out by OSHA and NIOSH to be a mask that you might be able to wear on the job. Why does this matter? So it matters because even though a basic surgical face mask is not at the level of the N95 material, it turns out that at the particle size in the 5 to 10 micrometer range that COVID is commonly believed to be transmitted in, that even basic cloth masks have mechanically close to 100% filtering efficiency. The problem is, unless there's a seal, air and these particles will follow the path of least resistance around the mask. However, if you can apply a brace that increases that seal and everything goes in through the mask material, you achieve something like 100% filtering efficiency for these viral particles, and the supposition is then that you would be able to decrease the chances of viral transmission. I wish that this was just an academic question, but unfortunately, even a year into the pandemic, N95 masks are in short supply in the United States and abroad. Both for medical professionals and for the lay population. This will still be true in resource-limited populations, and so we hope that a cheap, easy solution like this, while not to the level of an N95, which we would certainly recommend when available, might provide an increased margin of safety, not just for healthcare providers, but people who work in healthcare environments, and then also people who work in resource-limited environments here and abroad. So with that, I'll finish up and take any questions. If you'd like to scan the QR code attached here, it'll bring up an open access version of this. We were lucky enough to have this published formally as a manuscript in the last year. So again, thank you for your time and attention, and have a great day.
Hi, my name is John Harmon, and I'm a medical student at UAB in Birmingham, Alabama. And I'm here to present my project, Characteristics of HIV Seroconverters in a Universal Emergency Department Screening Program. This project is completed along with Mary Michael Garber Kelly and Kelly Ross Davis, with Dr. Sonia Heath and Dr. Lauren Walter. As far as disclosures go, I have no disclosures. To begin with, HIV is an ongoing epidemic, disproportionately affecting the Southeast and the community that this project studied. Amazing advancements have been made in HIV treatment, but we need to keep in mind that HIV is also very preventable by multiple mechanisms, including pre-exposure prophylaxis medication, which has been proven to be effective at preventing both sexual and IV drug use associated transmission. Research has also shown that the vast majority of newly diagnosed HIV patients have had recent contact with clinicians, especially in the emergency department. We would suggest that the ED, in addition to its role in universal screening, is perfectly situated to identify those who are at risk before they ever get HIV and can link them for counseling and potential PrEP prescription. The question is, who is considered to be a good candidate? Thus, our hypothesis that characteristics of known HIV seroconverters can be identified for potential tailored pre-infection engagement. Now, you may be wondering if this talk is even relevant to you. I would suggest that if you work in the healthcare field, you take care of patients in any setting, and you are interested in seeing less people get HIV, the answer is probably yes. So how do we do this? First, we define this group of seroconverters, and I'll briefly define what we mean by that. These are individuals who had been seen by a clinician in the past, tested negative for HIV, and then went on to contract HIV weeks, months, or years down the road. In order to find this group, we pulled every positive HIV test in our ED from 2014 to 2019. Now that was 792 positive tests, and I went through every one of them. So of those, I was able to eliminate a large group of false positives, another group that were new diagnoses, but I could not confirm if they had a negative test in the past, yet another group that did have a test in the past, but already knew they were positive, and that left 130 new diagnoses. Of those, 48 of them I could prove with actual lab tests that they were negative in the past. The other 82 reported to our clinicians that tested negative in the past. Importantly, this is the group that we think could have been intervened upon. So having found this group, we first looked at some CDC-described indications for PrEP prescription, including history of sexually transmitted infection, history of IV drug use, history of high-risk sexual practice. We also recorded data on some selected demographics like age, sex, gender, race, insurance status, employment status, marital status, and zip code. We know that HIV disproportionately affects those with low socioeconomic status. We aim to get a better picture of who these patients are. We also looked at some selected clinical parameters like psychiatric illness history. We know that mental illness is an important comorbidity in people living with HIV. We also looked at number of sexual partners, CD4 count, viral load, and time to seroconversion to consider how sick are these patients? Are they capable of spreading HIV? Then quite simply recorded the percentages so they may be compared to pre-existing HIV data and use some basic tests to assess for non-random differences. So here's some results. Now we got a lot of data on these patients, but I'm gonna hit the highlights for you. Half of our patients had a history of mental illness. Nearly 60% identified high-risk sexual behavior as a risk factor. 40% of these patients had been seen or even treated for an STI in the last year, the most common of which was syphilis. The most common presenting complaint in the ED was, interestingly, abdominal pain. And at the time of diagnosis, nearly 1/3 had a CD4 count already below 200. Thus, they're diagnosed with AIDS and are especially susceptible to disease-defining illnesses, including malignancies. This table shows some selected data from the group we identified to demonstrate if it is similar or different from pre-existing data on newly diagnosed HIV patients in both the Southeast and the United States as a whole. For example, if individuals who identify as male sex were very consistent compared to both the regional and the national data. But Black patients were way overrepresented in our community, whereas Hispanic patients were way underrepresented when compared to the regional and national data. Individuals who identified IV drug use as a risk factor were also overrepresented in our cohort. So in conclusion, this study has revealed characteristics that may be predictive of future risk of seroconversion and provide guidance for more tailored PrEP counseling. In Birmingham, Alabama, this is namely a younger, publicly insured, predominantly African-American population with IV drug use representing a significant risk factor. Now, we took the opportunity to take a step back and consider what the data is telling us. Some of these patterns were similar to the regional and national data, but some were not. The same pattern is found in reviewing the relevant literature. There is no one-size-fits-all approach, but rather, I would suggest, each organization that is interested in pre-exposure intervention should consider studying their own communities. The question is, does this work? So more studies need to examine the feasibility of using this tailored approach to PrEP prescription, considering the very real challenges of PrEP uptake. Researchers here at UAB are doing just that. Thank you so much for your time. I'd be happy to answer any more questions you may have.
Good afternoon, everyone. My name is Melissa Hart, and I'm a patient navigator at Jersey City Medical Center Center for Comprehensive Care. Today, I will be presenting results from our study on optimizing hepatitis C screening using automation in an urban emergency department. We have no financial conflict of interest to disclose. However, I would just like to note that the FOCUS program is a private, non-commercial grant funded by Gilead Sciences. FOCUS funding only supports screening and linkage to medical appointments after diagnosis. In April 2020, the CDC added 2 new recommendations for hepatitis C screening. These recommendations include that adults aged 18 years and over should be screened at least once in their lifetime and pregnant women during every pregnancy. Previous guidelines for screening focused primarily on screening individuals in the birth cohort, so people born between 1945 and 1965, and people who report a risk, so high risk including injection drug use. The changes by the CDC makes hepatitis C screening universal and also makes it a part of routine healthcare. Prior to these changes by the CDC, Jersey City Medical Center in February of 2019 implemented opt-out screening models in their emergency department for all patients who are eligible. The purpose of this study is to compare the effectiveness of hepatitis C opt-out screening versus an automated screening method in a fast-paced urban emergency department. So in February 2019, we implemented our opt-out workflow. So when the patient comes to the emergency department, our EMR system, Cerner, determines if a patient is eligible for hepatitis C screening. A patient is eligible if they are over the age of 18, no prior tests in the past year, and are getting blood work done. If the patient is considered eligible, the ED nurse is prompted a task to complete an opt-out form in the EMR system. The nurse then goes to the patient at bedside to have a conversation regarding screening. After that conversation, the nurse goes back to her computer to document. There are two outcomes: the patient opted out and is not screened for hepatitis C, or the patient did not opt out and is screened for hepatitis C. So on June 9th, 2020, we were able to automate this workflow. So when a patient comes into the emergency department, patient is eligible for hep C screening, meaning they are over the age of 18. They had no previous hep C tests in the past year. And when the physician goes to order any type of blood work for the patient, hepatitis C is automatically attached to that order and the patient is screened for hepatitis C. So there are some differences to consider. So with automation, it is not dependent upon the nurse, it's less steps, and it also is not an opportunity for the patient to opt out. So we compared our screening volume 30 days before and after automation. So as you can see from the graph, once we implemented automation into our emergency room, the volume of hepatitis C screening increased significantly. So before automation, we had a daily screening average of 10.4, a 30-day volume of 555, 20 antibody reactive, and 8 RNA positive. After automation, we saw that a daily screening average increased to 69.7. Our total 30-day volume increased by 566% for a grand total of 3,699. We identified 71 antibody positive, and of those 31 were RNA positive. So there are benefits of having an automated screening model. It is a more natural workflow for a fast-paced urban emergency department. The screening is integrated into a routine task for the nurse. You screen more eligible individuals, and it alleviates any stigma related to hepatitis C screening. So in conclusion, an automated screening is an effective method to screen and identify more individuals who are positive for hepatitis C and require linkage to care. By linking more clients to care, you increase their quality of life and also decrease further transmission of hepatitis C in the community. Thank you.
Good afternoon, everyone. My name is Katerina Truss. I'm a current PGY2 at Cleveland Clinic Akron General's Emergency Medicine Program, and I will be presenting our research study today on improved hospital mortality rates after the implementation of emergency department sepsis teams. Sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response, which leads to significantly high mortality. In the last year, there was over 700,000 hospitalizations for patients with sepsis and over 200,000 deaths per year. Surviving Sepsis campaign has established evidence-based guidelines that focus on early recognition of patients with sepsis and implementation of treatment bundles to obtain source control and optimize perfusion in these patients. Our objective of our study was to compare in-hospital mortality rates pre and post implementation of sepsis teams in the emergency department. So what exactly is a sepsis team? Patients meeting criteria for sepsis teams either have 2 SIRS criteria plus suspected infection after the initial evaluation by the provider, or have confirmed infection during any course of their workup. Once 2 SIRS criteria were met with the probability of infection, a sepsis team was alerted overhead. A team consists of a physician, resident, or APP, in addition to the nurse and a pharmacist. All of these individuals gathered together and established time zero on the sepsis checklist. At that time, a 3-hour treatment bundle is drawn. This includes a lactic and 2 sets of blood cultures. We also provided fluid resuscitation with either normal saline or lactated ringers if their lactate was greater than 4, or if they're significantly hypotensive with a MAP less than 65. We also initiated broad spectrum antibiotics at the time. Establishing time zero is a big factor in the study, as we want to identify any barriers to care which may impact this time. This includes patients with difficult IV access, patients with severe antibiotic allergies, or lack of resources such as nursing capabilities to complete these tasks. Once a patient is followed on the sepsis treatment plan, if they remain in the emergency department following the 6-hour mark, a repeat bundle is obtained. This includes repeat lactic and repeat perfusion assessment and need for vasopressors if they had persistent hypotension despite fluid resuscitation. This was a retrospective chart review. We included all adult patients at Cleveland Clinic, Akron General, who were non-pregnant and presented to our facility from October 1st, 2018 to March 31st of 2020 with the diagnosis of sepsis, severe sepsis, or septic shock. We did allow for a 3-month washout period from the initiation of sepsis teams. We had a total of 1,188 participants in our study. Moving on to our results. So we had a mean age of 64 years old. Majority of our patients were white and had Medicare. We did have a statistically significant lower mortality rate. We ran a logistic regression and had an adjusted odds ratio of 0.47, excuse me. And we also noticed significant improvement of our secondary outcomes of our time metrics. Again, looking at our primary outcome here, we had a statistically significant lower mortality rate. There was a 53% decrease in mortality after implementation of sepsis teams. Moving on to our secondary outcomes, including time metrics that we measured in the emergency department, including ED length of stay and ED time to admission. These were both statistically significant and had decreased lengths post-implementation of sepsis teams. In addition, we looked at time to drawing the lactate, time to blood cultures, and time to antibiotics. Time to lactic and time to antibiotic implementation were statistically significant. Some key takeaways to our study. So overall, early recognition of sepsis is imperative to decreasing patient in hospital mortality. The use of sepsis teams in the emergency department leads to overall better patient outcomes. Our study also showed improvement of majority of our secondary time metrics. We need to anticipate any barriers to care and or lack of resources, which could decrease compliance with our treatment bundle and overall affect patient care. And lastly, continual education of healthcare professionals is necessary to acknowledge patients with sepsis, recognizing them earlier, and ensuring compliance with sepsis bundles. I would like to thank all of my co-authors that helped contribute to the study, and I am available for any questions. Thank you.
Hi, everyone. My name is Rohit Sengal, and I'm an administrative fellow in the Department of Emergency Medicine at Yale University. So today I'm going to discuss some of our COVID testing data in a high-burden COVID region. For me, it's New Haven, Connecticut, from early in the pandemic. So if we think back to a year ago, we remember that testing resources were limited, and so they were first rationed to patients with certain travel histories, and eventually they were expanded to folks who had respiratory symptoms, fever, or clinician concern for COVID. But this led to some conflict between inpatient and ED teams, as one side would feel the patient did not have concern for COVID, and another would, which led to some issues with testing and bed assignments. But worse, there were these reports of false negative COVID swab rates being as high as 20% in the literature. Some issues with these previous studies were they were smaller samples, pooled analyses, or even using non-FDA approved tests. So this caused even more conflict, as an initial negative swab might be followed up with multiple additional swabs, which not only wastes time, bed assignments, but also the valuable resources of the swab itself. Now, we know that the duration of symptoms and swab quality can affect the result, but it's really not realistic to perform a bronchoscopy for every patient. So we tried to examine the results of our COVID swabs to determine a false negative rate in order to give real-world data to our teams. So for the first 8 weeks of the pandemic, we examined all COVID swab data for ED admissions, which realistically was everyone being admitted to the hospital, given that the ambulatory procedures were postponed. And we looked at how many positive, negatives, and repeat swabs were performed. We then chart reviewed the swabs that had multiple negative tests to see if there was a presumptive diagnosis of COVID or any other qualitative factors that might lead to a false negative result. So this flowchart breaks down the different results. There were about 1,900 total patients, of which about 35% were positive on the first swab. Of the patients who had a negative first test, 12.5 were re-swabbed, and only 4.4% of those second swab were positive. When you examine the patients that had 2 negative swabs, so the first swab was negative and the second swab was negative, a chart review of those patients revealed that 5.6% had a clinical concern for COVID and a presumed diagnosis of COVID. So overall, about 10% of patients with a first negative COVID swab were considered COVID positive. We then constructed a 2x2 table, taking the results of the previous flowchart, and we calculated the observed false negative rate, which is just 1 minus the sensitivity, and came up with 2.3%. So we found that 12.5% of patients, or 1 in 8 patients, were getting a second swab, but specifically our finding of a false negative rate of 2.3% should actually reassure clinicians and hospital administrators that the PCR test is pretty good. Yes, the quality of the sample collection is important, but early in the pandemic, everyone was highly motivated to obtain a good swab, and we even had specific teams trained to do all the swabbing. I will mention that the data might miss some patients who died before a second swab even had an opportunity to be collected. We actually took a closer look for this specific case, and we found that there were 9 patients who died within 48 hours of ED admission. None of them had a presumed diagnosis of COVID, but if they were considered to be a false negative, then that 2.3% would actually increase to 3.4%, so still a small number. But with this real-world data, we were able to get support for not re-swabbing patients, which not only saved our testing supply, but also reduced qualitatively the reports of conflict that were occurring in the ED. So with that, we had thanks to the great collaboration we had between lab medicine and the Department of Emergency Medicine, and I'm happy to take questions.
Thank you for listening to our talk entitled Factors Associated with HIV Testing Among Injury Patients in Kigali, Rwanda, conducted in partnership by Brown University and the University Teaching Hospital of Kigali. We would like to acknowledge funding by Brown Emergency Medicine Foundation, Brown Physicians Inc., and the NIH Emerging Infectious Diseases Scholar Grant. An estimated 38 million people live with HIV globally, and Rwanda, with an HIV prevalence of approximately 3%, potentially the biggest bottleneck for meeting the UN's 90-90-90 goals, is that an estimated 20% of people remain unaware of their status. It has been thought that emergency departments can serve as an outlet for testing and linkage to care, especially to key populations with inadequate engagement to HIV care who may be especially affected by injury, such as young adults and males. The goal of our study was to determine factors associated with the provision of HIV testing among injury patients at the ED of the University Teaching Hospital of Kigali, Rwanda. This site, which is Rwanda's national public referral hospital and has an ED volume of over 20,000 patients annually, served as our study setting. We enrolled a prospective cohort by screening all adult injury patients enrolled from January to June of 2020, barring a 2-month lockdown period from March to May due to COVID-19. Our primary outcome was provision of HIV testing during the patient's hospital stay. Mann-Whitney and chi-square tests were first used to query differences in variables between patients receiving and not receiving testing. Subsequently, we used significant variables to generate a multivariate regression model with backward stepwise regression to assess predictors of HIV testing. Our study was composed of 579 injury patients, with 76% being under the age of 45 and 74% being male. 86% did not have significant prior medical history. Exclusions can be visualized by the flowchart on the left, with the most common reason being under 18 years of age. Over 80% of patients presented with one or more serious injuries, with the most common causes being road traffic accident and fall. 54% of patients also received surgical consultation within 6 hours of admission, and 77% received an acute ED intervention. 41% of patients were admitted for inpatient care, whereas 59% were discharged from the ED. For HIV testing, our primary outcome, 221 patients or 38% underwent testing, and of these, 13 or 6% tested positive. This table displays variables that were significantly different between patients receiving and not receiving testing. Significant variables associated with HIV testing included male sex, no serious injuries, lower Glasgow Coma Scale score, lower Kampala Trauma score, which denotes a higher injury severity on admission, pre-hospital transfer or transport, receiving surgical consultation or an acute ED intervention, admission to the hospital, and admission after COVID lockdown. When we put these variables into a multivariate model, we determined that there were 5 significant predictors for HIV testing. First, male sex. Second, lower KTS, which again denotes a higher injury severity on admission. Third, pre-hospital transport. Fourth, surgical consultation. And fifth, admission to the hospital as compared to being discharged from the ED. Next, we conducted a sensitivity analysis stratifying patients based on their time of admission. Specifically, we separately analyzed the 69% of patients who were admitted before the COVID-19 lockdown and the 31% of patients who were admitted after the COVID-19 lockdown, with the figure on the left visualizing weekly ED volumes. The tables on this slide indicate the results for regression models for patients admitted before the lockdown on the left and after the lockdown on the right. Importantly, for both models, discharge from the ED was negatively associated with provision of HIV testing in both time periods analyzed in the sensitivity analysis. In conclusion, there is a modest level of testing in Kigali's ED currently, with only 1/3 of injury patients presently receiving testing, but there is some evidence that it is reaching underrepresented populations who are traditionally not linked to HIV care, such as young adult males. One consistent finding was that many factors predicting HIV care reflected higher injury severity, such as a lower Kampala Trauma Scale score on admission and intensity of care, with the most important variable predicting whether patients received HIV testing being whether or not the patient was admitted to the hospital as opposed to being discharged from the ED. As a corollary, the majority of patients discharged from the ED did not receive testing, which may represent a lost opportunity for connecting injury patients to HIV care. Finally, the increase in HIV testing after the lockdown also warrants study. We are interested in characterizing if this change is due to differences in resources or care patterns between these 2 time periods. This slide contains our references. Finally, I would like to thank my mentor, Dr. Adam Aloisio, our collaborators in Kigali, and funding support for making this project possible. Thank you very much for listening to our talk, and for any questions, please reach out to oliver_tang@brown.edu. Thank you very much again.
Good afternoon. My name is Greg Griffin. I'm a current PGY2 resident at Cleveland Clinic Akron General, and I'm excited to be able to share my research today, which is faster treatment times and reduced mortality in sepsis seen at freestanding versus hospital-based emergency departments. I do not have any disclosures. So the research question, which we had, was to evaluate patient outcomes, mortality specifically, who presented with sepsis, severe sepsis, or septic shock to freestanding emergency departments versus hospital-based emergency department. Our secondary objectives were to evaluate differences in patient population, i.e. were patients sicker at freestandings versus hospital-based EDs, demographic differences as well. We also wanted to evaluate key sepsis treatment times and evaluate length of stay between freestandings and hospital-based emergency department patients. Our study design was a retrospective cohort study. We used adult patients 18 years and older who were not pregnant, and we used 3 freestanding emergency departments and 1 hospital-based emergency department within a single hospital system. The time frame in which we did the study was January 1st of 2018 through October 30th of 2020, and we selected patients that had a primary diagnosis of sepsis, severe sepsis, or septic shock. Data collection was used using Epic's internal data warehouse Clarity to identify these patients and their hospital admission identifier of sepsis, severe sepsis, or septic shock. Our results, 1,955 patients were included in the study. 361 were patients that presented to freestanding emergency departments, and 1,594 patients that presented to a hospital-based ED. So primary result, initially we'll look at mortality. As you can see here, freestanding emergency department had a mortality of 2.77%, and patients who presented to a hospital-based ED had a mortality rate of 11.48%, and this result was statistically significant. In order to control between the patient populations, we use the Charlson Comorbidity Index. As you can see here, freestanding emergency departments had 3.91, Charlson Comorbidity Index compared to 4.86 for the hospital-based emergency department patients. This result was statistically insignificant and therefore shows that these patient populations are somewhat similar. Next, we looked at time interventions for initial sepsis bundle. And as you can see below, time to IV, time to lactic acid, and time to blood cultures were all statistically significant, showing that freestanding emergency departments were able to perform these tasks quicker. Time to antibiotics, however, was not statistically significant between the two groups. And then secondly, we looked at time to disposition. So we looked, when did these patients actually get their disposition of admission to the hospital, when they left the emergency department, and when they actually achieved their inpatient status in the main hospital. And as you can see, all 3 of these results were statistically significant for freestanding emergency departments being able to achieve this goal quicker. So in conclusion, patients presenting to the freestandings had a 73% decrease in mortality. Patients presenting to the freestandings had initial interventions that occurred earlier than the hospital-based ED, and patients presenting to freestandings had quicker disposition, transfer, and inpatient admission status. I just want to say thank you to everyone who's helped me with my study, and I'm now open for questions.
Welcome. Our research is entitled, "Does the presence of household children lessen the severity of COVID-19?" I'm Isabella Yuna Chang, and I will be presenting this work on behalf of my team members, Jacqueline Liu, Ashara Ta, and Andrew Chang. This research was conducted at Albany Medical Center in Albany, New York. By way of background, we know that there are 7 coronaviruses. 4 of them listed below cause the common cold. Then there is the original SARS coronavirus, which caused severe acute respiratory syndrome in 2003, MERS coronavirus, which caused Middle Eastern respiratory syndrome in 2012, and the current SARS-CoV-2 virus, which is responsible for COVID-19. We know that respiratory viral infections are transmitted by virus-contaminated respiratory secretions. We also know that children are often found in close contact with other children in certain settings, such as daycare or schools, thereby repeatedly exposing themselves to all sorts of viruses. Children likely pass on their common cold coronaviruses to their parents, who in turn develop protective antibodies to these common cold coronaviruses. We therefore wondered whether antibodies to common cold coronaviruses may lessen the severity of the novel SARS-CoV-2 virus. We tested this hypothesis by comparing, based on presence or absence of household children, differences in percentages of mortality, hospital admission rates, ICU admission rates, intubation rates, hospital length of stay, and presence of COVID symptoms. This study was approved by the Albany Medical Center Institutional Review Board. We accessed an internal analytics app which tracks all patients tested positive for COVID-19 at our medical center. Patients between 21 to 50 years of age were called from March to August 2020. After verbal informed consent was obtained over the phone, we then asked a series of survey questions that lasted approximately 15 minutes. Major survey questions included the number and ages of any children living in the same household, and the presence of 25 different COVID symptoms. Data was entered into REDCap. T-tests were used to assess differences between means, while chi-square, or Fisher's exact test, were used to assess differences between dichotomous variables. Out of the 203 potential patients, 23 were excluded due to their phone number not being in service or them being prisoners. 24 declined to participate, and 71 were unable to be reached, leaving us with a cohort of 85 patients. Out of these 85 patients, 60% were female, 47% were white, 18% Black, 16% Hispanic, and 8% Asian. As this was done early on into the pandemic, 49% were healthcare workers. The age was evenly distributed, 34% between the ages of 21 to 30, 35% between the ages of 31 to 40, and 31% between the ages 41 to 50. This is a table of our main results. Of the 85 patients with COVID-19, 55 had children living at home, while 30 had no children living at home. 38.2% of patients who had children at home were admitted to the hospital, compared to 36.7% of patients who did not have children. This difference of 1.5% was not statistically significant, with a p-value of 0.9. Of the patients who were admitted, 5, or 23.8% of those with children at home, were admitted to the ICU, versus only 1, or 9.1% of those with no children, for a difference of 14.7%, though this result was not statistically significant. Similarly, 4 patients, or 19.1%, with children at home were intubated, versus no patients who had no children at home, for a difference of 19.1% that was also not statistically significant. 2 patients, or 3.6%, who had children at home died, versus none who did not have children at home, for a p-value of 0.5. Mean length of stay for COVID-positive patients with children was 5.9 days, versus 3.9 days for COVID-positive patients without children, for a difference of 2 days and a p-value of 0.4. Of the 25 COVID symptoms, only loss of smell demonstrated a potential trend towards significance, with 34.5% of those with children at home reporting loss of smell versus 56.7% for those without children at home, a difference of 22.2% and a p-value of 0.057. Sub-analyses using different age cutoffs for children, including ages 5 or less and ages 11 or less, did not change our findings. Our study had several limitations, one of which was the fact that it was conducted very early on into the pandemic, and only 2 patients who died were enrolled. In conclusion, having children of any age did not result in a decrease in morbidity in patients with COVID-19. Thank you.
Hello everyone, my name is Dr. James Ford and I'm giving this presentation on behalf of myself and my colleagues at UC Davis Health. Today I'd like to talk to you about a study entitled Identifying Risk Factors for Syphilis Positivity Following Implementation of an Emergency Department-Based Screening Program. This work was supported by Gilead-funded Front Lines of Communities in the United States, or a focus grant. Apart from this funding, the authors have no other disclosures. After decades of decline, syphilis prevalence is increasing in many countries, including the United States, where between 2000 and 2018, syphilis prevalence quintupled. Despite the rapid increase in emergency department-based infectious disease screening programs, using the emergency department as a setting for public health intervention still remains controversial. In 2018, the study institution implemented an electronic medical record-based alert that prompted syphilis testing in patients being tested for gonorrhea and/or chlamydia. In this study, we aim to identify risk factors for syphilis positivity in emergency department patients in order to further tailor screening protocols. We performed a retrospective cohort study at a single tertiary academic emergency department in Northern California. We included adults over the age of 18 who were tested for syphilis between the months of November 2018 and August 2020. Our study institution uses a reverse sequence syphilis testing algorithm where patients are first screened for treponema pallidum antibody, IgM, IgG, and those that are positive go on to receive reflex rapid plasma reagent testing to confirm the diagnosis. The outcome of interest was the number of new syphilis diagnoses, and we conducted a risk factor analysis using multiple logistic regression, and we report adjusted odds ratios and 95% confidence intervals. Here are our summary statistics for our study population, which was a total of 1,974 patients. The median age was 33 years, and most patients were female, about 56% of the population. And here is the race distribution for our study. Here are patient characteristics dichotomized between syphilis status. So a total of 201 new syphilis diagnoses were recorded during our study. Age was similar between the two subgroups, but patients that were syphilis positive were more likely to be women. There were no significant differences between race between our subgroups, but patients that were syphilis positive were more likely to be homeless. And the same table continued here. Patients that were syphilis positive were also more likely to have a history of HIV, a history of tobacco use, a history of alcohol use, a history of illicit drug use as well. There was no significant difference in insurance type between syphilis positive and syphilis negative patients. Here is our risk factor analysis, and these are the 6 variables that trended in our bivariate analysis with syphilis positivity. And in this multiple logistic regression risk factor analysis, we find that history of HIV was the most strongly associated risk factor for syphilis positivity, followed by history of tobacco use, undomiciled status, and history of illicit drug use. So in summary, undomiciled housing status, tobacco use, history of HIV, and illicit drug use were all independently associated with syphilis positivity. So broadening targeted syphilis screening algorithms could potentially improve screening catchment and identify new cases for treatment. Here are a list of my references, and thank you for your time today.
My name is Tom Hagerman. I'm a resident at Henry Ford Hospital, and I'm going to talk about connecting patients diagnosed with HIV in the emergency department to care during the COVID-19 pandemic. We have a single disclosure listed on the slide. In 2018, the CDC estimated there were 36,000 new HIV diagnoses and a population prevalence of about 1.2 million people, 7% of which are estimated to be unaware of the diagnosis. HIV screening in the emergency department plays an important role in helping end the HIV epidemic and has shown to be both effective at identifying new cases of HIV and connecting patients to outpatient care for treatment. In November 2019, we started a non-targeted opt-out screening process at Henry Ford. Patients with positive screens are contacted by an infectious disease nurse after ED discharge for follow-up. And since starting this screening, we have successfully identified numerous patients with HIV and connected them to care. But then came the COVID-19 pandemic, which has caused major disruptions to ED operations and changes to the patient mix in the emergency department. COVID has also greatly impacted outpatient care, which is a crucial component of a successful ED-based HIV screening program. In the earliest weeks of COVID, there was a significant decrease in total outpatient visits, and the majority of medical specialties saw significant decreases in visits. A survey of 161 programs funded by the Ryan White HIV/AIDS program, which provides care to about half of all people with HIV in the United States, also showed that HIV prevention and support services took a significant hit during COVID. In this survey, about 28% of providers reported shutting down all or most of their HIV prevention services, and 15% decreased their HIV support services. With all of the disruptions to normal clinical care caused by COVID in mind, there was the potential for disruption at multiple points of our process, including drawing the screening tests itself, but also getting positive patients connected to outpatient care. Therefore, we had the question of how did the COVID pandemic impact our screening rates and our rates of connection to care? We had 2 aims in this project. We first wanted to compare the rates of HIV screening before the pandemic and during the pandemic to determine if ED operation changes and nursing demand changes or shortages impacted the already established opt-out HIV screening program. Secondly, we wanted to compare the rate of connection to care and the average time to specialist appointment between the 2 periods. To do this, we defined a 4-month pre-pandemic period from November 2019 to March 12, 2020. We used March 13th as the start of the date of the pandemic period, as this was the date in Michigan when mandates from the governor went into place that would impact people's daily life. We compared this pre-pandemic period to a 9-month period during the pandemic from March 13th to December 12th, 2020. The two periods were not equal in length because the program was not fully operational until November 2019. To move on to results, the number of screening tests per month, when not adjusted for ED volume, was slightly higher in the pre-pandemic period, with an average of 1,600 tests per month compared to 1,300 tests per month during the pandemic period. However, when adjusted for ED census, the rate of screening in the two periods was similar. 35.8% of all patients visiting the ED were screened in the pre-pandemic period, compared to 34.7% of patients that were screened during the pandemic period. Seeing that the rates of screening did not change during the pandemic, we then wanted to determine if the rate of connection to care was different. In the pre-pandemic period, 25 patients were diagnosed with HIV and 27 were diagnosed with HIV in the pandemic period. Importantly, 6 cases of acute HIV infection were identified during the pandemic period, which has important public health implications as this is a period of high infectivity. Furthermore, the rates of linkage to care were not significantly different. All 25 patients in the pre-pandemic period were linked to care. During the pandemic, 22 of the 27 total HIV positive patients were linked to care, or 81% of all positive patients. And 88% of all living patients were linked to care, as 2 patients died prior to be able to link to care. And notably, all 27 patients during the pandemic were contacted and notified of their diagnosis. However, 3 patients declined being linked to care. We also wanted to compare the average time to first appointment to evaluate the impact of outpatient care changes during COVID. Although the average time to first appointment was almost 1 day longer in the pandemic period compared to the pre-pandemic period, this difference was not significant. Overall, we found that in the first 9 months of the COVID-19 pandemic, we maintained rates of screening comparable to the 4 months prior to the pandemic. We overall screened about 35% of patients that we saw in the emergency department. The only currently available study that also looks at HIV screening in the emergency department from the University of Chicago shows a screening proportion of about 25%, which also did not change in the early days of the pandemic period. We think that the most likely reason that our screening rate did not change during the pandemic period was because of the very limited workflow disruption of the current HIV screening process. Physicians do not have to click any extra buttons unless they want to decline the HIV test. And nurses do not have to draw any extra blood work. We're only getting this blood work if a CBC or other lab work is already being ordered. Another key to the continued success is nursing buy-in and support for this screening, as they're the ones that are informing the patients of doing the test. And moving forward, advocating for financial support, especially for the work that is needed to follow up on patients after ED discharge to get them connected to care is really essential. Without a streamlined process for follow-up, the screening in the ED would not be feasible. I've included a list of references, and I'm grateful for the help of Kim Mumby, who is the infectious disease nurse that is at the head of this operation.
Hello, my name is Shannon O'Toole, and I will be presenting on emergency department visits for gastrointestinal chief complaints after the arrival of COVID-19. There are no actual or potential conflicts of interest in relation to this presentation. Now, just as a background, we previously showed that there was an increase in respiratory complaints in the New York metropolitan area upon the arrival of COVID-19 on March 10, 2020. Previous studies have shown that as many as 79% of COVID-19 patients also have gastrointestinal symptoms. Therefore, we hypothesized that the number of GI chief complaints and the proportion of GI complaints to total ED visits increased after the arrival of COVID-19. We did a retrospective cohort study composed of emergency department visits in 21 hospitals within 150 miles of New York City. The hospitals were both teaching and non-teaching and included all areas from suburban, urban, and rural. The time frame was from March 10th to December 23rd in 2019 and 2020. We identified the GI visits using a GI syndromic surveillance filter for chief complaints, and then we tallied the total number of ED visits and the number of visits for GI chief complaints. We analyzed the visits for pediatrics and adults together and separately, and then calculated the change from 2019 to 2020 for visits in GI complaints and the proportion of total ED visits with GI complaints. The results show that there was a decrease in total ED visits from 2019 to 2020. In 2019, it went from 802,323 down to 579,366 in 2020. The total visits with GI complaints also decreased. In 2019, it was 46,583, and in 2020, it was 25,490. This represents a decrease of 45% in GI visits. Now, some people would say there just wasn't as many people coming into the emergency department that during this time. It's just a reflection of the sheer numbers. So we then calculated the proportion of patients with GI complaints. In 2019, 5.8% of ED visits had GI chief complaints, while in 2020 only 4.4% did. This represents a decrease of 24%. And then when both adults and the pediatrics were analyzed separately, they both showed a decrease, and there was a greater decrease in the pediatric age group. Therefore, contrary to our hypothesis, both the total number of ED visits for GI complaints and the proportion of GI complaints to total visits did not increase with the arrival of COVID-19. We speculate that the decrease in the total number of GI chief complaints found were due to just a general overall decrease in ED visits with the arrival of COVID-19. However, it is still unclear why the proportion of visits with GI complaints also decreased. Thank you.
Good afternoon. My name is Alex Dunn, and I'm a research coordinator at the Hennepin County Medical Center. I'm excited to have the opportunity to present this project to you, the effect of mobile phlebotomy on participation in an outpatient clinical trial of patients with COVID-19, a project I was the primary coordinator for. By way of disclosures, this project was funded by the Minnesota Partnership for Biotechnology and Medical Genomics. This organization was responsible for funding the study and had no role in the use or decision to use mobile phlebotomy for outpatient visits. There are no other conflicts of interest to report. In terms of background, there have been limited treatment options for the outpatient population of those with COVID-19. COVID has caused a disruption to our usual research processes as well as many other groups around the country. It has limited our ability to have face-to-face interactions due to risk of infection. Another limitation is the quarantine-related transport restrictions, specifically for those that might take the bus or Uber or other means of public transportation in our area. In addition, consent and safety labs have also become barriers for enrollment for this project. Prior to our intervention, we would screen patients, and then we would conduct remote electronic informed consent. From there, the patient would return to the clinic or our emergency department for vitals and safety labs, and then from there on would be randomized. We noticed that this caused a 29% loss to follow-up. Once we recognized this barrier, we introduced our intervention, mobile phlebotomy. In terms of the logistics of this intervention, once we consented a patient, we would dispatch our mobile phlebotomy unit to the patient's household to collect vitals and safety labs and then return it to the hospital. After safety labs were resulted, the patient could be randomized. The identified advantages included less PPE per patient seen, less time commitment from research staff and study participants, as well as the removal of travel barriers and the concern of quarantine. Disadvantages included the coordination of multiple schedules, that being that of the study staff, the patient, and the mobile phlebotomy team, as well as the costs associated. We hypothesized that the implementation of mobile phlebotomy would increase our trial enrollments as well as decreasing the rate of appointment absences, also known as loss to follow-ups. We conducted retrospective data analysis of our screening logs between the months of April and November of 2020. We looked at the screen date and exclusion criteria which were recorded prospectively as part of the study. Our primary cohort included patients that met medical inclusion and exclusion criteria for trial participation. Our primary outcome was the proportion of patients excluded specifically due to insufficient transportation pre- and post-implementation of mobile phlebotomy services. As a secondary outcome, we analyzed the proportion of patients excluded due to transport barriers or not showing up to their lab appointments pre- and post-mobile phlebotomy implementation. Finally, we looked at the rate of enrollment, controlling for background changes over time. In terms of data analysis, for the primary outcome, we used a 2-proportion z-test, and for the secondary outcome involving enrollment rates, we used multivariable logistic regression. As part of a post hoc analysis, we contacted patients that were consented prior to our mobile phlebotomy intervention that had missed their safety lab appointment, asking them if mobile phlebotomy had been available, would you have made your appointment? We screened 9,602 patients for this study, with 8,576 of those being excluded because they did not meet the medical inclusion-exclusion criteria. Of these patients screened, 1,026 met the medical inclusion-exclusion criteria. 540 of those were screened prior to our mobile phlebotomy intervention, and 486 were screened after. Of those that were screened before, 10.2% consented to participate, and of those after the intervention, 4.9% consented to participate. We found that prior to our intervention, 2.8% of participants refused to partake in the study exclusively due to lack of transport. After the mobile phlebotomy intervention, 1.6% of patients refused due specifically to lack of transport. Looking at our composite outcome, when no-shows were taken into account, 5.4% of participants were excluded in the pre-intervention phase versus 2.9% of participants in the post-intervention phase, which was statistically significant. When taking into account our multivariable model, we did not find that mobile phlebotomy was a significant independent predictor of trial participation. We found that the overall rate of study consent decreased over the course of the trial. This was independent of our intervention as it occurred prior to safety labs in the order of operations. As you can see here, our intervention was associated with an increased odds of participation in the trial, that being an odds ratio of 2.16. That being said, this was not statistically significant. In conclusion, mobile phlebotomy services did not significantly affect the number of participants explicitly excluded due to lack of transport. However, mobile phlebotomy services did improve the composite outcome that included the appointment no-shows. Still, it did not significantly affect trial enrollment rates. Lastly, I'd like to give recognition to our PIs and our research team at HCMC for all of the hard work they've put into this trial. Thank you for the opportunity to share this with you, and I'd be happy to take any questions.